Good afternoon, everyone. Welcome to Medical Grand Rounds. Before I introduce our introducer, I want to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous people. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Thanks everyone for coming. Our speaker today is from the Division of Cardiology, and I'd like to invite our Chief of Cardiology, Dr. Atul Verma, to introduce our speaker.
Hello, everyone, and it gives me great pleasure to introduce our speaker. I'm sorry that I'm in the lab right now, but our speaker today is Dr. François Tournoux. We are very pleased to have Dr. Tournoux join us as a new cardiology staff here at the MUHC. He is an associate professor, and we should also congratulate him on getting his senior designation in the FRQS. We managed to bring François from the CHUM, where he was the director of the Heart Failure Clinic and was previously the president of the Quebec Heart Failure Society. Dr. Tournoux trained at the University of Paris and did an echocardiography fellowship at the Massachusetts General Hospital in Boston. His research interests are really in artificial intelligence, echocardiography, automation, as well as the novel organization of processes. And so it's only right that today he's talking to us about organizational and technological improvements and innovations to improve access to echocardiography. So thank you very much, Dr. Tournoux, for giving us these rounds.
Thank you, Dr. Verma, for this kind introduction. Thank you, everyone, for this invitation. So I'm just going to start by my potential conflict of interest with this topic. I got a quality improvement grant from BMS about the access to echo for patients with hypertrophic cardiomyopathy. And I'm currently applying for grants with Roche Diagnostics and Ivado Labs, which is a company which is building algorithms for AI. So the objectives of this presentation is to present you the recent INESSS guidelines and discuss how they could be implemented. These guidelines have been created to increase access to echo for our patients, to introduce an example of lean project management in our echo lab, and to discuss the current and future role of AI to support our initiatives. Let's just start by giving you a little bit of a context. Transthoracic echo is, as you probably know, a key examination for all patients presenting with symptoms or signs of cardiovascular pathology, suspected or confirmed. There has been a continuous and significant increase in demand for echocardiography. So just over the past 10 years in Quebec, more than 4% increase. And in 2009, a little bit more than 200,000 examinations were performed in the province versus more than 300,000 in 2018. Access to transthoracic echo. So there is a continuous and significant increase in demand for transthoracic echo. And access to transthoracic echo is becoming increasingly delayed. Just at MUHC, 39% of the outpatients on our waitlist have been waiting more than 6 months for their echo. Why is that? Well, the echo lab has limited capacity to increase volume, and indication for transthoracic echo keep growing in cardiology, but also in other specialties like oncology, for example. On this slide, I put you what is the classic workflow for a patient coming from an echo in our lab. So we start by receiving the request, we schedule the patient, we figure out if we need transportation, if it's an inpatient, and manage to bring the patient inside the echo lab. The patient is scanned, the images are getting interpreted by the echocardiographer. We need to make sure that our machines are in good standing, that our data are well managed. we are an academic institution, so we usually have research program in parallels. We have to make sure that the quality of what we do is meets our standards. And then finally, at the end, the report is finalized and sent to the physician who asked for this test. So the problem is we have too many requests and our capacity is limited. So how can we solve this issue? So the usual strategies are, try to save more slots for MUHC patients and try to decide that we cannot accept patients from other institution or outside offices. We can also decide, to try to hire more technicians, but unfortunately, as for nurses, technicians are rare, and even if we are very interesting position, it's difficult to find new ones. We can try to increase the workload of our technician, but if we do that, definitely they might leave or they will get injured, which is even worse, and it's counterproductive. So another strategy, and it's what we try to develop inside our lab, is to target inappropriateness and inefficiency. And I'm going to work for the next slide on an example, which is a specific context of heart failure. So in heart failure, transthoracic echo has an essential role from diagnosis to monitoring treatment. And we know that delays in echo evaluation can lead to irreversible cardiac sequelae and poorer prognosis. And most of the time, people say, well, I will just order an echo, it's non-invasive, there's no radiation, it's not going to harm my patient, which is true, but in inappropriate transthoracic echo request for one patient might in fact harm another one because the other patient will have his echo delayed. 20% of our transthoracic echo requests at MUHC are related to heart failure, either because it's suspicion of a diagnosis or because we want to follow the patient, monitor the efficiency of the treatment that we are giving to these patients. 20% of these requests are expected to be inappropriate if we just look at our local statistics or when we look at what has been reported in the literature. That's why, considering the number of echo which are asked every year within the province, the fact that a lot of requests might be inappropriate, INESSS decided to create a recommendation in a report which is called Usage optimal de l'échographie cardiaque au Québec dans le contexte de l'insuffisance cardiaque chronique. So you have in this document 7 recommendations which are based on clinical expert consensus. How it works, it's basically this algorithm. I'm not going to go to detail this one, but basically it's based on the fact that a patient with a suspicion of heart failure, except if your clinical suspicion is really high, you should first ask for a dosage of natriuretic peptides and ask for an EKG. And if your peptide is normal, natriuretic peptide dosage is normal, and if your EKG looks normal, then probably echo is not the first exam to ask for patients who has a suspicion of heart failure or who just short of breath. So it's an interesting algorithm. We know that other countries, like in the UK, they are using the same principle and making sure that patients who has signs or symptoms of heart failure get the NT-proBNP first before asking for an echo. So how can we integrate this algorithm within our current workflow? So it has to be really at the beginning of the process. And our hypothesis is that INESSS recommendation probably should improve the access to transthoracic echo for patients referred, for example, in the context of heart failure, by reducing the number of inappropriate requests, ensuring that TTEs are performed at the appropriate time and with the appropriate priority. But the issue is that implementing this recommendation in our echo lab, it's a major challenge in terms of change management for the team, because the safety and effectiveness of this recommendation is not really proven. They have never been validated in a clinical environment, and most of the healthcare providers who refer patients to our echo lab are unaware of these recommendations. So our goals are to develop an innovative process to rapidly implement this recommendation, to determine their impact on patient benefit and safety, to ensure change management for the team, and consequently adjust our practice within a process of continuous improvement. So we have designed several projects in the echo lab to try to implement these guidelines in our process. We do that using what we call a lean project management strategy. Basically, we follow different steps, which are well identified. We initiate the project, have everyone around the table, and I'm talking about not only physicians, but also the sonographers, the secretaries, the management. We plan what we want to achieve, what our goals. We execute the project. We make sure that by changing something, we don't harm another population in the lab. We make some adjustment if it's needed. And at the end, we close the project with our results, and we try to move to the next one. So in the echo lab, to be honest, it's something which is difficult to implement. And so instead of starting right away with this big project of trying to implement the INESSS recommendation, we decided to first work on the stress test. The reason why is because stress tests are performed also in the same division as echocardiography. It's in the non-invasive cardiology department. And we use stress tests also when we do stress echo. And it's, we had some problem and a small wait list for this test, but it's much, it's easier to try to fix and to use that as a first case for this kind of project. So what we did, we took all the technicians, physicians who were interested in trying to improve our process and put them around the table. And what they did, they, tried to create the workflow of a patient coming for stress test until the finalization of the report. So as you can see here on the wall, everyone used a few small post-its to put IDs, what has been done, what has been improved. And it was especially interesting in our institution because we have two sites. We have the MGH and we have the Glen. And interestingly, people were not doing stress tests the same way in both sites. So the line above the green, the blue line above the green one is what's happening at MGH, and the blue line below the green line is what's happening at the Glen. And so each post-it represent one step, an ID, and or a potential problem that needs to be solved. And if I can zoom on this wall, you see it's very simple things, and we put time. So, okay, the patients come for this step. So at RVH, it takes 30 seconds to 2 minutes. At MGH, the same. So let's move to this next one. So we doing that, we can find out what are the differences, what the team at MGH did to improve one process which was not optimized at the RVH, and so on. And by doing that, we were able to gain in terms of productivity. And so we increase our capacity by 10 to 20%, which is basically every day. By doing just this simple work, we were able to add one stress test at each clinic. And so to do one extra patient with the same staff, no extra technician, no overtime, and no other needs for a new physician or whatever. So just by optimizing our process. Once we are finished with this first step, which is to figure out if the request is appropriate, the next one is to try to optimize the rest of the workflow. And so the question is, could we use AI to help us with that? So the first one is scheduling. Can we use AI to help us to schedule our patients better? There was some initiative already in the US, and this is an example in radiology department, where people use AI to optimize the slots of the patients and make sure that their scanner or MRI machine are well used, and that, to limit the number of no-show. So basically what the system is doing, it takes all the information that they already have about the patient within the EMR. Is it a frail patient? Is it a young patient? Does this patient will need an IV? Does this patient is known to be a no-show patient? But also take some information from other sources, like what is the traffic of the hospital? What is around the hospital when it's time to do an MRI at 10 a.m.? What is the forecast? Is there a risk of having a snowstorm, or is it going to be sunny, etc.? And using this information, they were able to optimize their schedule. And so they show that they were able to obtain a 71% reduction in patient wait time, a 6% increase in the utilization of the machines, with no increase in workload for the scheduling staff or for the operational. So a lot of benefit of using this algorithm to schedule these patients. And currently we are working on a similar project for Ecolab using AI to optimize our slots. The second step is, okay, can we try to use AI to optimize our transportation system and manage our human resources a little bit better? So there was some projects. This is one which was done in my previous institution at the CHUM in radio-oncology, where they developed an algorithm to make sure that the workflow of the patient between the different schedulers is optimized. So between the medical visits, imaging, the labs, infusion therapy, the radiation therapy, and the pharmacy. And using AI to make sure that the schedule is optimized, they were able to increase by 11 hours their capacity per day. They saved $250,000 per year. And in fact, to train new clerks, it was taking 50% less time. And the administrative people, they even liked it. And there was an 80% reduction in administrative burden in this project. So that can be definitely used also to improve our workflow. The third step is, can we use AI to accelerate the scanning of our patient? So AI has already been implemented in our echo machines. So this is currently what's happening. So for example, you have a patient which was in the past known to have bad images. And then when you apply some echo algorithm, you are able to optimize the image. So it makes them easier for not only for the sonographer to capture, but also for the physician after to interpret. AI is also used during the exam to maintain some quality control. For example, here the system will indicate by a green box that the image is of good quality versus this one where it's a red box and the image is considered as bad quality. And finally, the system is able to label each views and make sure, for example, that the sonographer didn't forget anything while they were scanning the patient. We use also AI to improve the quality of the images, to train our new sonographers. So we have now some systems where you can indicate to the trainee where to put the probe, and if the way he puts the probe, it's the right way to do it. So when it's a green bar here, it says that the positioning is good. When it's red, it means that the student has to change the way they are scanning. And the system will also add some label on the different cavities to indicate what you are looking at. So for example, here, it automatically find out this is a LV, mitral valve, left atrium, etc. Once the patient is scanned, then we can use AI also to do echo interpretation. And so there are different AI applications now to support image interpretation, which are already, for some of them, within our system. So you have, the first one is image labeling. So for different tools that we are using when we are reading echoes, we need to make sure we use the best image. And sometimes, when a patient is scanned, we have 100, 120 images, and it's hard to figure out exactly which image we should use. So using AI, the system will automatically pick the best one and will already perform half of the analysis for us. So it's a gain in time, which is really significant. The second thing is that it will also facilitate what we call segmentation, which is basically, especially in the context of measuring the ejection fraction, a key element. So here you have what we were doing in 2006 when I was a fellow at Mass General in Boston. In order to measure the ejection fraction of a patient in 3D, I had to manually, most of the time, correct the shape of the detection between the endocardium and the cavity. I spent so many hours doing that. And now, with new AI algorithm, we train the system to recognize what a human would do in terms of segmentation. And now, in our current echo machine, you do one acquisition, you press one button, and you get immediately your result with a very great accuracy. So this is really, again, a big game changer for us. What people show is that using this AI algorithm has decreased by 77% the measurement time. It has also reduced by 45% the measurement variability. And we know that in echoes, this has always been an issue between different operators, but using AI algorithm already help a lot to reduce this variability. And finally, with this AI system, we are able to retrospectively analyze a lot of echo in our database and to do it in a very, very fast way. And I'm going to rediscuss that a little bit later. Another place where AI application can help us to support image interpretation is quantification. Some of you who are seeing, for example, oncology patients under chemotherapy, they know that besides the ejection fractions that we use as a marker to make sure that the patient doesn't have any cardiotoxicity, other tools have been developed to have a better understanding of the myocardial function and try to prevent a drop in EF before. So the way to do that is to do really a precise analysis of the contractility. And these tools have been really developed in a fast way over the past 2 or 3 years with the help of AI. So now we used to have systems to make a very complete understanding of what's going on at the level of the left ventricle, but we're able to do it for the right ventricle and the right atrium and the left atrium. So we have now tools who are going to help us to detect cardiac disease or toxicity of drugs much before we see a drop in the ejection fraction. Another step is to use AI to do auto measurements and auto interpretation. So auto measurement, that's a little bit easy. We just ask the AI system to detect the different flows that we record with our echo Doppler machine and to give us the numbers. It's quite easy for an AI system to do that, but it saves us sometimes when we are reading the echo. But the interesting thing now is that the AI system are able to integrate different information coming from different measurements and to give you a diagnosis. So this is an example of a patient with an aortic stenosis. The AI system has been able to analyze the size of the LVOT, the gradient, and to calculate from all this information the aortic valve area and say, well, I think this patient has a severe aortic stenosis. And the interesting thing is it's not just science fiction. FDA just recently approved one of this software for cardiovascular ultrasound analysis. And most of the parameters we are currently using when we read an echo can be interpreted by a machine. Finally, the next step is sometimes to use AI to try to suggest diagnosis. We know that AI is able to detect patterns or red flags which are suggestive of different disease, even if the human eye has not been able to figure them out. And the nice thing is that AI can limit itself to echo, but can also use information from other databases, like the EKG database, for example, and integrate all this information to suggest a diagnosis. And this is an example of the group in Boston, where they use EKGs, echoes, they mix the information, and the system was able to identify patients with a potential cardiac amyloidosis versus patients with another diagnosis like an hypertrophic cardiomyopathy or AVH linked to hypertension. And with a great accuracy, this is what the software is doing. The small cross here is an expert in amyloidosis, and here is an expert in echocardiography. So the machine was even slightly better than the human reader. Of course, in imaging lab, we are processing a lot of data. we have to store them, and we have to make sure they are appropriately classified if we want to research that the labels are appropriate. So there are a lot of tools to assist us in this task, and the place of AI is growing rapidly. It can be used for research with the power of making ultra-fast and low-cost analysis of tons of data. And I take this opportunity to let us know that the CIM, the Center for Innovative Medicine, we just opened a research ecolab. So it's really like the clinical ecolab, but we have the same machines, same technicians, and just for research. And to my knowledge, we're probably one of the first one, at least in Quebec and maybe in Canada, to use one of these AI-based reading software to analyze the echocardiogram. So it really helped us to cut in our cost and to also offer service of retrospective analysis of huge echo databases. So if anyone has a clinical trial in the past with raw data from the echo, we can reanalyze all this data in a few days. The software is just running by itself overnight. Finally, the last step is the control of the quality of what we are doing. So as I showed earlier, AI can be used to control the quality of the acquisition of the images, but also we can use AI to scan our echo reports and test the variability between different readers in the lab, and test the quality of the report itself, its wording, etc. With the advent of ChatGPT, there are a lot of options which are being prepared. And so it's going to be of huge help to control our quality. So finally, is there any barriers to the rapid expansion of AI in our ecolab? Well, any software using AI is performing well if it has been well trained. And the issue currently for researcher is to find large echo databases where everything has been properly labeled by humans, so we can train the machines with good data. The second barrier is the size and the diversity of the databases which are available. One typical example is the Mayo Clinic. They are doing a lot of research in AI, but when you look at the paper, sometimes the databases are just white men with a poor representation of women or patients with Afro-Americans. So if you train a system with a specific database, you cannot use it in another institution where your population can be completely different. The third barrier is the slowness of healthcare institutions to move to a digital world. Some AI systems, they need to have access not only to your echo database, but to other databases as well to be efficient. And since we are still working in silo for many things, this is something which is slowing us. The cost and benefit ratio is also unclear. Building algorithm for AI costs a lot of money, and we have to make sure that the benefit, either in terms of dollars or for the patient, is really real before investing more. Quality control is important because these algorithms are made by engineers. We don't always control the way the code has been done. We are not sure what the AI system figure out in terms of, for example, patterns to suggest the diagnosis. So we need to create system to control the quality of the AI algorithm that we have built. And finally, there are legal and ethical consideration. And if I go back to the scheduling system that I presented earlier, if you enter, for example, in your database, the social status or the job of your patients, and the AI system figured that poor people sometimes there are more no-show in poor people versus rich people, then the AI system will propose, for example, double booking for poor people and regular booking for rich people, which is really not what we want, because instead of reducing inequities for a patient in terms of access to echo, we're just going to increase it. In terms of legal issues, if the AI system make a mistake, who's responsible? Is it the company which built the algorithm? Is it the hospital and the doctor who bought the system and are using it? In fact, it's still something which needs to be more discussed. The issue is, most of the time, the companies which are building this algorithm say that this algorithm can only apply in specific conditions within specific barriers. And when we are using them, we forget these barriers and limitation. So it's really a process where we should use this algorithm, make sure they are of good quality, know their limits, know the barriers, train our staff, and tell them when you can use them, when you should use them, and when you shouldn't use them. And that way, we make sure we get the most benefit from this technology. So to conclude, I would say that despite the lack of sonographers, the budget cuts, and all the other challenges that we are facing, there are currently options to improve access to echocardiography, which merit to be tested. Where I show you, the principle of lean project management. I show you a few examples of the use of artificial intelligence, knowing that this needs to be a responsible use of this technology. But if we optimize each segment of the care trajectory for patients, we review our procedures, standardize our protocols, and accept change, then with the support of new technologies, we might be able to succeed. Thank you very much, and I would be happy to take a few questions.
Thank you. Thank you very much, François. Very nice, comprehensive presentation on the topic, and glad to see some evolution in the way that we are functioning in this particular imaging test that's in very, very high demand. Okay, there's a comment. Sasha, do you want to mute yourself and ask your question?
So it wasn't a question. It was just, I was reflecting that it really seems to me like the wait times for echoes in our lupus patients, we order them often because we're thinking about pericarditis or have chest pain and it doesn't resolve with treatment. So we're wanting to determine like that aspect, but it seems to me like the wait times are much less. I don't know if it's related to other factors, but I'm really happy about it either way.
Well, happy to hear that. Thank you.
François, you know those little handheld, I think they're called V-sign machines that we have?
Yeah.
Should we be doing more of those and formalizing those? Do you see any role for that?
So all the point of care ultrasound systems, I think it's an area of major development. A lot of companies are working on getting machines as cheap as possible, especially because there's a new way to create probe, a new technology which is coming, which is going to reduce the cost of these systems by at least half of it. also without environmental issues that we are currently facing with our current Echo probe because it's using a lot of lead. So this new technology coming will make access to Echo for every clinician if they want. Currently, the main user are probably people in the emergency room. I saw a lot of doctors training for point-of-care ultrasound, using them to do some triage in their patients. They can use that not only for the heart, but also abdominal rapid scanning. They are really useful. The key thing is how we keep the images, make sure everything is safe, that if there's any problem later on, we can review that. We don't have at MUHC a good system to do that so far. In the US, where they used to do that already a few years ago, they have system where now all the images are saved on the PACS, it's well labeled and saved. And what they've shown is that it really helps them to prioritize, for example, the echo request for the main lab from the emergency room. So if a patient has a normal POCUS in the ER, while the echo can still be asked, but can be done as an outpatient, when the POCUS shows that patient is in severe heart failure, then the normal regular echo should be done as fast as possible.
Okay, thank you. Dr. Rosenblatt, you can unmute yourself.
Yes, first of all, thank you. That was really a beautiful and clear presentation. My questions are a little bit philosophical because I see some analogies in what's happening with molecular testing and genetics in terms of organizations, and also some general lab issues in terms of the importance of pre-analyticals of samples coming in, because there's so much wasted because samples are sent in without correct information, and also for unnecessary testing, which costs the system a fortune. But my question is more on the private side. So how much echo is being done privately, both in Canada and the United States, as revenue generators, where, of course, the goal is to have as many negative tests as quickly as possible to generate income. So do you see this as a potential problem down the line in Quebec as AI becomes better, interpretation becomes better, and people with less training are able to set up shop and offer services?
Yeah, so it's a very good question. So actually, I think our the best way to try to figure out what could happen is to look at what's happening in Ontario. So in Ontario, you can have your echo within 1 week in a private clinic. There's a lot of small centers who offer this service. Of course, in Quebec, you can have an echo in the private sector, an echocardiogram in the private sector, but a patient will have to pay it from his pocket. So what we see is that already in some clinics in Ontario, they are using some AI software to do the report. I know the companies that we are using actually at the SIM already told me they have some customers in private clinics in Ontario. So this is happening. People are using the system to increase their efficiency and to work faster. And that's why I think it's really important that we do quality control of what's happening in our institutions. Otherwise, it's an open door to n'importe quoi, which is always something that I'm worried about. Only already in our own echo lab. So we have all these great tools I presented for sonographers. They are doing the acquisition, and they let the machine make some measurements automatically to save time. But I noticed, especially over the past few weeks since we get a new software, that some sonographers don't question what the AI system did. And I tell them, why you didn't measure it? They say, well, the machine said that was that, but do you think it's right? I said, well, I didn't think it was right, but I didn't want to fight the machine. So it's kind of interesting that, people with a lot of experience, if the AI system says this is the way you should measure it, they are kind of embarrassed of trying to, say, well, maybe the machine is wrong. So we need to teach and train our students, our staff, to do an appropriate use of this technology. I think it's a new field in education, actually, that we need to develop, and but it's really, really important.
François, I'm covering the CCU this week, and we've taken a lot of transfers from outside hospitals. And the first thing that we do when they arrive is we do our own echo here. And I'm wondering, they've all had echoes in the hospital prior to coming. Is there any data? I mean, certainly, in Quebec, echoes are done within institutions. There's no, RAMQ, as you mentioned, doesn't pay private echoes. So is there any data looking at, consistency of echo, either local, within Quebec, or sort of, are there any data to show that you don't have to keep repeating echoes as you transfer from one institution to another?
Yeah, so this is a very good question. The issue with echocardiography is that if you try to look at the report, for example, in the DSQ, you never find it. Okay, and the reason is that because we are not part of radiology, because we are cardiology. So somehow we got excluded from the DSQs. It's not completely 100% truth. In some institutions where people are doing echocardiography in the radiology department, you might find the echo report in the DSQ, but in 95% of the cases, the echo report is not there. So, and when you are in the DSQ, the images are there as well. And that's what the radiology is doing. Sometimes it just download the images from another institution to compare the images with a scan, or to reanalyze some data. I did that in the past with nuclear medicine, for example. I wanted to have a second opinion from a doctor of our institution. So I think if we at some point are able to give access to the whole province to our images, then there's no need to repeat an echocardiogram which has been performed 2 days ago in another institution. Then we can just download the images, check the report, check what were the images, and it will save us time and money. So I hope with the advent of a PIC system that's supposed to be for the whole province, it will help us in that matter. The other things that people are doing, and we are going to try to do one test with an hospital in the region of Gatineau, is that we can, using technology developed by Philips, transfer data from one institution to another one. At least when a local community hospital want to have our opinion on one patient. So instead of sending the patient to a MUHC to repeat the echoes, they will just send us the images, and we can do that even when they are scanning the patients, and we can even take control of the echo machine from MUHC. So this is a pilot project that we plan to do for next year. But this is kind of initiative that I think can help us to reduce the amount of echo which are done 2 or 3 times. And I agree with you, it's not always necessary.
Thank you very, very much. Are there any other questions? Okay, if not, we're coming up on the hour. Dr. Tournoux, thank you so much for sharing this, for first of all, being here and advancing this technology at the MUHC and access to this technology at the MUHC. And thank you for this really comprehensive, excellent presentation. I wish you all a good afternoon. Bye-bye, everyone.
Thank you very much.